So again, I tried to do things a little bit differently this year. So in this afternoon, I'm going to do a workshop on ankle marrow edema. Of course, to me, that's probably the single most confusing thing I have in reading MR images, because recognition is not the problem. It's, as one of the participants brought up in a break, it's the diagnosis that's the problem. But since there's actually just too much to put in there, and marrow edema doesn't only occur in the ankle, I have this introductory talk on general concept of marrow edema. The what is marrow edema, where it occurs, what are the causes of it, the why, and lastly, the when, which is when it causes symptoms. And look, hopefully at the end of this talk, I'll have time to do that. So the overview of this talk is we're going to give a definition of what marrow edema is, talk about the etiology of marrow edema, a little bit about the role of different sequences in terms of specificity and sensitivity, some common variants that cause marrow edema, and then looking at marrow edema from a morphologic basis, looking at several morphologic findings, most notably kissing lesions and crescentic lesions, and end with what types of marrow edema more frequently cause symptoms. And this is an example of a T2 fat suppressed image of the femoral head with an area of avascular necrosis causing a crescentic appearance in the anterior aspect of the femoral head. So what is marrow edema? The pathologists, they argue back and forth about whether it really exists or not, and the truth is it does exist, and edema is really not a bad term for it. But what it really is leakage of fluid from vessels. So things that can cause trauma to the vessels, things that can alter the permeability of those vessels, or things that alter the profusion that comes from the vessels, all things that cause marrow edema. So obviously there's a lot of different pathogenesis for this, which we will talk about, and in particularly, a lot of times we see what looks like marrow edema but is really normal. Marrow edema is something that recognition is not difficult as long as you have a fat suppressed image. You see it. It's knowing exactly what it is in a differential that's hard. And so we're going to talk about using different sequences, using morphology, adjacent tissues, and there is no crime in using history to get to a correct diagnosis. And here is an example, a coronal proton density fat suppressed image. We all see the marrow edema in the lunate. We know it is in the radial aspect of the lunate, so we know it's not impaction syndrome. If I told you the T1 was normal, we know it's not Kienbach's disease, and there is no differential for this. This is from a cartilage defect on the proximal aspect of the lunate. I didn't see the cartilage defect prospectively. I called it. It was seen at surgery, but you know it has to be there. So now we're going to talk about sequences. There's a patient with sickle cell disease in an area of infarction in the navicular, the calcaneus, and the tibia. And we see all three of these better on T1 than we do on the inversion recovery image. This is something I mentioned earlier when looking at the sesamoids. Certain things, most notably AVN and metastases, are usually seen better on T1 weighted images. So what happens is normally we identify the area on a fluid weighted image. It's the most sensitive sequence for all marrow edema, with the notable exception of some metastases. If you don't do a T1 weighted image, you can miss metastases. I've been burned on that several times. The unfortunate thing is these fluid weighted images are nonspecific, so we have to do a T1 weighted image. So one simple thing about protocoling is proton density images are great when we're dealing with internal derangements. If you're dealing with marrow or anything outside of a joint, always do a T1 weighted image. Use your T2 weighted images to see the marrow edema, and notably to evaluate the soft tissues around it. Not because you need to see the soft tissue edema, but the appearance or morphology of that edema will help narrow your differential diagnosis. So a low field strength scanner, we have a very thin rotator cuff here with a bursal-sided partial tear, and we see edema in the anterior aspect of the humerus. We see this all the time. And posteriorly, it's a normal variant, but anteriorly, it's usually a marker for rotator cuff disease. So it's the location in this situation, not the appearance. But you always need a T1 weighted image. Your T1 weighted image tells you the severity of that edema. How overt the edema is will give you a window into the severity. And if you don't see it at all on a T1 weighted image, it's usually reactive edema to something going on around the bone. The more you see it on a T1 weighted image, the more overt it is, the more severe the edema is. And I'll give you an example. If I see a stress injury in an athlete and the T1 is normal, that's a stress response. But if the T1 is abnormal, that's a stress fracture, whether I see the fracture line or not. If I see an ulcer in a diabetic, and I see maroedema on an inversion recovery image, if the T1 is normal, that is not osteomyelitis. If the T1 is abnormal, that is osteomyelitis. So your T1 weighted image is your window into severity. Last example, I have a traumatized knee. I see edema in a lateral femoral condyle. If I see that on a T1 weighted image, that may be an occult fracture from a patella dislocation. If I don't, it's a bone bruise, also possibly from a patella dislocation. Here's an example. Here we see cystic change in the distal aspect of the clavicle, and we see edema medial to that. We hardly see this edema on a T1 weighted image. In fact, this marrow is iso-intense to the glenoid. This is reactive edema from this resorption here, and this is post-traumatic osteolysis of the clavicle. Another example, a child with elbow injury. We see nothing on the inversion recovery image, but we see complete marrow replacement on the T1 weighted image. Things that are overt on T1 are AVN and metastasis. And this is Panner's disease, as Dr. Ryback talked about, necrosis of the capitella. So we want to grade the severity of the edema and narrow the differential diagnosis. We use some fat-suppressed image to find the abnormality. We use our T1 weighted image to grade the severity and consequently be more specific. We also grade the severity by how large the lesion is, and then we narrow our differential diagnosis based upon where it is and what the soft tissues around it look like. Now, this has probably been somewhat confusing already, but I'm going to bring up one point, which, to be honest, makes it a little bit more confusing, but it's very important. And that is the degree of edema you get in a given bone is based upon the trabecular cortical ratio of that bone. The higher the ratio of trabecular to cortical bone there is, the more of an edematous response you'll get. And you've all probably seen cases of ulnar impaction of the wrist, where the ulnar is impacting on the lunate. You invariably see the maroedema in the lunate, but not in the ulnar. That's because the cortical envelope is relatively thicker in the ulna, so you don't develop a edematous response. On MR, we miss posterior element fractures in the spine, but we never miss vertebral body fractures. In fact, we see them a lot of times when you can't see them on any other modality. We miss them in the posterior elements because they're a sparse trabecular. Therefore, they have a low trabecular cortical ratio. We see them in the vertebral bodies because we have a high trabecular cortical ratio. So when evaluating the severity, you have to throw in how sparse the trabecular are. And we're going to go through examples of this. Here's an example. This is a patient who has a tarsal coalition. They have a hypoplastic sustentaculum tali. And we have reactive edema here seen only on a stir on both sides of the joint. We'll talk about the importance of seeing edema on both sides of the joint shortly, but that usually means there's an articular basis for the disease. Here's a patient with Prizer's syndrome, avascular necrosis of the navicular and we see the edema on a T2. It is quite overt on a T1, and we see the soft tissue reaction around it, the edema oozing out. So we talked about the definition of edema. We talked about using your T1 as complementary to your inversion recovery or fat-suppressed image as a window into severity and as a way of gauging specific diagnoses, most notably AVN and metastatic disease. And we talked about looking for that edematous response with the knowledge, if you can, which is not easy, of the trabecular cortical ratio, because that's going to influence how much edema you'll see on a fluid-weighted image. Now we're going to talk about some normal variants, because philosophically I think you need to cover normal variants first before talking about pathology. And the first normal variant that can cause red marrow, that can cause marrow edema, is red marrow. And we see this in characteristic places, and it is listed in your CD handout, but here is an example of one. This is a patient who has a complete tear of the distal biceps with a large amount of fluid in the bicipital radialis bursa. But I note to you this edema in a distal radius right by that insertion. This is a common normal variant that can look just like a fracture. Fractures of the radius occur close or at the articular surface. They don't occur down here at the bicipital tuberosity, but this can be very striking, and it shows you how red marrow can be very bright on a fat-suppressed fluid-weighted image. Another example, this is all red marrow in the medial humerus and in the glenoid, and even in subarticular bone. There are two bones in your body that have subarticular red marrow. The humerus is one, and the analogous lower extremity femur is the other one. And this is just red marrow giving you the appearance of marrow edema. The next variant that can cause marrow edema are penetrating vessels. We talked about this in the shoulder where we can see them posteriorly. But I think they cause the most problems in the wrist. And here is an example. If you just looked at this T2 weighted image, you might wonder, is this rheumatoid arthritis? Does this patient have CPPD arthropathy? I see all these cystic lesions in multiple carpal bones. But in the posterior lunate, we have a penetrating vessel. In the capitate waist, we have a penetrating vessel. In the posterior triquetrum, we have a penetrating vessel. And at the scaphoid tubercle, we have a penetrating vessel. So all these areas are normal. The patient happens to have a scapholunate ligament tear, cartilage loss, and an intra-articular body. This edema is not normal. This edema is not normal. And this edema, as Dr. Aurora talked about, is from a type 2 lunate. But this is a normal variant, as is most of the cystic lesions. So penetrating vessels can cause marrow edema. In your handout are the typical locations. I find it the most difficult in terms of reading cases in the wrist. The other areas I don't find as difficult. The last variant that can cause marrow edema is children. And this is usually adolescents. It is not red marrow. This is accelerated bone turnover from rapid growth during puberty and can cause striking areas of marrow edema, characteristically in the lower extremity, but also sometimes in the wrist. And anyone who reads any pediatric patients has seen this all the time. And if you're like me, have scratched your head or pulled out what little hair you have left, trying to figure out what it is. This is entirely normal. It is not red marrow. It is bone turnover during the peak of bone growth, usually 13 or 14 for boys, a little bit younger for girls. This is analogous to the edema we see following stress in adults. This is a patient who had a cast on, had the cast taken off, and complained of pain in their foot. And we did this MR, and we see all this patchy area throughout the foot. Looks very similar, I think, to the edema in this child. We did another MRI 2 weeks later, and that marrow edema completely resolved. The cast was off, There is increased bone turnover as the patient is adapting to ambulation. It's the same principle. Rapid bone turnover causing asymptomatic marrow edema. So we talked about the definition of marrow edema. We talked about using sequences to help you gauge the severity and narrow the differential diagnosis. And we talked about 3 variants that cause marrow edema: red marrow, bone turnover at skeletal maturity, and penetrating vessels. And now we're going to do our next group of signs to narrow a differential diagnosis, and those are morphologic signs. And this is an example of one. This is a low field strength scanner. This is a very overt peripheral TFCC tear, but we see the reactive marrow edema, which one of my ex-fellows recently presented at the RSNA, as a secondary sign of peripheral TFCC tear. We don't see this on a T1 weighted image. This is reactive marrow edema. We'll talk about that. So before getting to morphology, you have to know a little bit about how the edema is going to behave to understand its shape. And really all you need to know is that marrow edema is basically non-contained. My wife doesn't like when I use ooze in a slide, but I really can't think of a scientific word that sounds better than ooze. If you have marrow edema, it's going to ooze. It's going to ooze through Haversian canals and be in the periosteum. It's going to ooze into the sinus tarsi and give you sinus tarsi edema. It's going to ooze into a joint and give you an effusion. It tends to ooze, and that's one way when looking at the soft tissues to help you understand the marrow edema. And here's a case of the sinus tarsi. This is a patient with calcaneocuboid articular disease. We see the kissing marrow edema telling you that it has to be articular disease. But if you just looked at the region of the sinus tarsi, you might mistakenly say there was pathologic edema there or there was something wrong with it. This is just the edema oozing out into whatever is nearby. Another example, an insufficiency fracture of the femoral condyle, something that most of you knew as SONC, and I knew as SONC until fairly recently. But what we see here is this is a joint effusion, and we see soft tissue edema around this medial femoral condyle. This is the edema oozing out through the Haversian canals. So getting now to more precisely about abnormal morphology. Where is it? Which bone is it in? Which part of that bone? Is it at the edge, which usually means it's traumatic or from cartilage loss? And what do the soft tissues look adjacent to it? Do I think it is reactive? Do I see a fracture line? Does it appear infiltrative? These are all questions that I ask myself when trying to evaluate the morphology. A sagittal low field T1 inversion recovery image of the spine. We see diffuse infiltrative edema of the vertebral body, as Dr. El-Khoury pointed out earlier, extending into the posterior elements, bowing the posterior aspect of the vertebral body. Classic for a pathologic compression fracture. Getting to specifics, the first morphological point we'll speak of is impaction. And there are variants of impaction. The first variant is when you see 2 contralateral bone bruises, either in the ankle or the knee almost always. The impaction side bone bruise is always more obvious. So if you see an obvious bone bruise in a lateral femoral condyle, a subtle one in the medial, that's an MCL sprain. If you see an obvious bone bruise in the medial talus and a subtle one in the lateral fibula, that's a lateral ankle sprain. So the impaction side, which will be contralateral to the soft tissue injury, gives you the more overt bone bruise. You can also get impaction fractures, often but not always secondary to dislocations. You can get depressed fractures, which you can think of also as impaction injuries. And in the non-traumatic spectrum, AVN also gives you impaction. So when we have impaction, I think of dislocations, plateau fractures, ligament injury, and AVN. Again, 4 things in my differential. So here is a coronal PD, a coronal fluid weighted image of the tibia, and clearly there is a depressed lateral plateau fracture, one of the things in a differential. Here is a patient. We see serpentine areas of high signal, but we see collapse of the articular surface with impaction. And AVN is another thing that gives you impaction. Another example of AVN. And dislocations give you impaction. And here is the impacted Hill-Sachs deformity of the humeral head. So impaction, contralateral to a ligament injury, depressed plateau fracture, following a dislocation, and avascular necrosis. The next morphologic sign we'll speak of is the crescent sign, something I alluded to in my earlier lecture this morning. The crescent has been considered a sine qua non for avascular necrosis. That's not entirely true. We also see this with articular disease as well as insufficiency fractures. So here is a T1 and a T2 weighted image of the humeral head, and we see the crescentic areas here with the double line sign characteristic for avascular necrosis. Another example of a crescent of the femoral head, characteristic for avascular necrosis. But you can also see crescents from articular disease. Here is a patient at time X, and we see this, and they come back 4 years later. I'm sorry, this is time X, and this is the 4-year follow-up. And this is an early subchondral cyst that evolves into a subchondral cyst, but looks like a crescent on an inversion recovery image. So not only do infarcts give you crescents, but osteoarthritis can give you crescents. Another example, a crescent also in the knee from osteoarthritis. Last example, another crescent, lateral femoral condyle perpendicular to the joint space. And this is an insufficiency fracture. So in any individual case, we're going to narrow our differential diagnosis based upon variable things. And morphology is one of them. And when you have a crescent, 3 things, AVN, osteoarthritis, and insufficiency fractures. And again, history will help you narrow them. The next morphologic sign we're going to talk about is kissing lesions, that are seen on both aspects of the joint space. And here is an example, a very obvious scapholunate ligament tear, but I demonstrate the case to show you the kissing changes at the navicular and the radial styloid. Kissing changes are almost always articular disease. So when they directly kiss each other, when they're directly adjacent to each other, it's always going to be articular disease. There's a variant of a kissing lesion where you see them on opposing articular surfaces, but they are cystic. And here is an example of one of them, a large cystic area around the PCL, and a smaller, very tiny cystic area at the insertion of the ACL. So again, when you see these cystic lesions around joints, they should remember like articular disease. They could be geodes or they could be away from the joint, related to ligament tension. But this is also articular disease, kissing lesions, this subtype being cystic. Next subtype of kissing lesions are non-contiguous kissing lesions. Kissing lesions that are opposed to each other are articular disease, whether they be cystic or not. Kissing lesions that are in adjacent bones but not opposed to each other are from trauma. And Dr. Mecklin is going to give a very nice workshop on bone bruise patterns, and I'll just show you 1 or 2 of them. And here's an example we all know. Posterior lateral tibia, anterior femoral condyle. contiguous kissing, and we all know this has to be an ACL tear. Another example, medial patella, lateral femoral condyle, non-contiguous but kissing, has to be bone bruises from a spontaneously reduced patella dislocation. One less variant of kissing lesion, which is a little bit harder to understand, and that is kissing that's related to articular disease, but you only see the edema on one side of the joint. And this is related to a concept I introduced earlier, that in certain bones will have more edema based upon the trabecular cortical ratio than other bones. So that to you should be like any other kissing lesion, but you just don't see the edema because they're a sparse trabecular. Here's an example of one. Chronic rotator cuff tear with atrophy. We have rotator cuff arthropathy with erosion and remodeling of the undersurface of the acromion. But we see much more marrow edema in the acromion than we do in the humerus. And this is also kissing, but we see less of, it's a subtler kiss, if you will, because of the thick cortical envelope and relatively sparse trabeculae compared to the acromion. Another example, one I mentioned earlier, central TFCC tear, ulnar abutment. We know these two are banging. We know it's articular disease, in a way of speaking, but we see the edema only in the lunate and really nothing in the ulnar adjacent to it. Again, that's related to the relatively pronounced trabeculae of the lunate compared to the distal ulnar. Next concept is an important one, and that is reactive edema. And this is going to go back to the beginning of my lecture. Reactive edema is subtle to non-existent on a T1 weighted image. And it's usually related to a soft tissue process. It may be an ulceration. It may be sinus tarsi syndrome. But most importantly, it's adjacent tendons. And here is an example. A patient with severe epicondylitis, and in fact a tear, and we see the edema adjacent to this. This is reactive edema, and in fact I can guarantee that this is the symptom generator and not the tendon tear. Another example, ankle, PTT, hypertrophic, all this reactive edema at where the PTT meets the tibia is reactive to the PTT. And that tells you this PT has to be abnormal, but this is the symptom generator. Lastly, what causes it and what does it do to my patient? So what causes symptoms? Anyone who has marrow edema has a risk, and not insignificant, that the marrow edema causes symptoms. Whether it be modic 1 changes in the spine, subtendinous edema in the ankle, or edema from articular disease in the wrist or the knee. And it may be difficult to differentiate the disorder from the reaction to the disorder, such that you have sinus tarsi syndrome and marrow edema adjacent to it. But in most people who have a soft tissue disorder, the marrow edema is the symptom generator, not the soft tissue disorder. In the last half an hour, we did an overview of marrow edema. We defined marrow edema as leakage from vessels. There's a whole different list of causes of marrow edema. You guys all know that. I emphasize using your T1 weighted image as a complement to a fluid weighted image to gauge the severity of the edema, and to remembering that METs and AVN tend to be more overt on T1 weighted images. Then we went through specific morphological signs, such as the crescent and kissing lesions. And we talked about the 3 subtypes of kissing lesions. And we also mentioned the concept that some normal variants, most notably bone turnover in adolescence, penetrating vessels, cause reactive marrow edema, and red marrow, cause reactive marrow edema and can look pathologic but are normal. And we finished with the concept that marrow edema can be reactive to a bunch of different disorders, And when it's reactive, you tend not to see it on a T1 weighted image because it's relatively mild in severity. But nonetheless, it is often a symptom generator.